we have partnered with an organization called the Red Hot Mamas. I did want to let you know that the Red Hot Mamas, they have a website. There is a lot of wonderful evidence-based content there. They also have a wonderful monthly newsletter that you can subscribe to. One of our speakers, Nurse Barb, is actually on one of their, is part of their board. And so we just really thought the information there was so valuable that we partnered with them. And so you'll see their name on the slides as we go through them here tonight. Their information will also be linked to our information on our menopause webpage, which is at El Camino Hospital /menopause. Our first speaker is Nurse Barb. So a lot of you are part of the I Love Barb club. Raise your hand if you are in that club. Yes, we love Barb. We are so thankful to have Barb be part of a lot of the work that we do here at the hospital. She's a phenomenal writer. She is so passionate about women's health. She is a nurse practitioner, still practicing even with her busy travel and speaking schedule. She is an award-winning author, and she has written a book that we actually have copies that we will be raffling off here tonight at the end of the presentation. Barb holds a bachelor's from Boston College, has her master's from UCSF, and is also a certified menopause practitioner as well. So with that, I will turn it over to Barb. Thank you.
Thanks, Bonnie.
Thank
you so much. Thank you, Bonnie. Bonnie does a great job here running the pelvic health program and the women's health program. If it's okay, I'm not going to wear the boa because even though it's really playful, and I think that's great with sex, at any age and stage, it is kind of shedding. And I also want to take a moment to say thank you to everyone who's here, and also to the men who are here. We're going to try to make it fun for you and educational, and maybe bust some myths. You probably watched that show, Mythbusters. There's probably some myths out there like, come on, what's the big deal? Sex is sex. Well, after a certain age, sex is a little bit different for us gals. And I think sometimes it's hard for men to say, wait a minute, the plumbing isn't that different, so what's the big deal? But we're going to talk a little bit about how things are maybe a little different. But let's start with perimenopause. Let me take this out of here. I'm the happy wanderer. So when a woman has her period, she starts having a period after puberty, and then we get to menopause. Menopause is when periods stop, right? Well, perimenopause is that magical time between when you have regular, predictable periods, and then you're having this time in your life where it's kind of like an emotional or hormonal roller coaster. So you never know when you're going to have your period. You don't know if it's going to be heavy. You don't know how long it's going to last. And if you can, I want you to remember, go back in time, all of the women and the men in here, go back to your childhood, before you ever had your period, and for the men, before puberty, before that growth spurt. Were you interested in girls? Okay, you're an outlier. For the girls, the women in the room, before puberty, or think about your daughters. Soccer, we don't care about boys. Before we had estrogen bathing our brains, we could care less, right? Your daughters, they don't care about boys. They don't care about one zit. They don't care about how they look. Estrogen bathing your brain. Now you care. You care about how you look. Now you have a sex drive, right? You care. Your breasts are budding. Well, perimenopause is like puberty in reverse. Only it's a roller coaster. It's not a nice, easy transition. It's a roller coaster with wide swings in hormones. And that's why a lot of women have wide swings in their periods. And they have wide swings in their sex drive. So some women will find that they're really, really interested for a day or two, and then they have no interest at all. They may find that they have a lot of hot flashes and night sweats. Now here it says that perimenopause can last for 2 to 10 years. Sometimes it can last a little bit longer. So what we know is that everybody's experience on this hormonal roller coaster is different. What that means is everybody gets a different ticket for this roller coaster ride. And what's really hard is that every month you get a different ticket. So there's no way to predict from one month to the next what's going to happen. So with perimenopause, a lot of women have hot flashes. They can't drink a hot cup of coffee because all of a sudden their makeup is running down their face. Anybody have that happen to them? Anybody able to take a hot shower? Right? How about a stressful email? Now all of a sudden you're sweating through your clothes. Or you're caught in traffic, you're late for a meeting, you're late for picking up your kids, now you're having hot flash. How many of you say, you know, gee, the back of my neck is awfully wet and warm in the middle of the night. I think I better stop putting on so many extra blankets. It couldn't be those night sweats from menopause, could it? How many of you have that? It's menopause. Hello. Those are called night sweats. Some of them are drenching, where you have to jump up out of bed, run into the bathroom, run cold water over you, or go outside, or move to Alaska. Hot flashes, night sweats. Some of you will find you have to go to the bathroom, you have the sensation in the middle of the night that your bladder's full, and then you have a night sweat. Or you have a night sweat and then you have to go to the bathroom. It isn't fun. Your sleep is interrupted, and like Bonnie said, you have 1 or 2 of these a night, you wake up exhausted, you don't know your kids' names, you don't know your name, and your partner says to you, hey, you want to have happy time? You're like, who are you? And I want to sleep. Hello? Because for a lot of women, if it's a choice between sex and sleep, what wins? Sleep. Thank you very much. Because we're not getting a lot of sleep. And if our partners snore, guess what? We're not very happy. So that itchy, bitchy, sweaty stuff, there's a lot of other causes. Battle of the Bulge. How many of you feel really comfortable taking off all your clothes with all the lights on in front of your partner? Raise your hand if you're that person. Where's Giselle Bundish in here? She in here, Tom Brady's wife? Are you in here, Giselle? Oh, no one. All right, except for one gentleman in the back who looks like Tim Robbins. Hello. Okay, I said to my husband, honey, have you noticed the cellulite? He goes, honey, it's a good gosh darn thing I wear glasses and it's dark. Very few people want to have, all of us have issues with body image. There's only 3% of people who don't have an issue with their body image, and they live in Brazil. And they're not menopausal, let me tell you. So all of us have issues with body image. And I want to talk about the Battle of the Bulge briefly. Any of you notice that overnight 20 pounds appeared right here? Any of you? Any of you rely on Spanx if you have to go to a wedding, a reunion, an event? Any of you? Any of you wish you had invented Spanx? Yeah, me too. I'm wearing Spanx right now. And it is not your imagination. I was at the North American Menopause Society meeting. Yes, there is such an organization. And we were shown data that once your estrogen levels drop, guess what else drops? Your metabolic rate. You can eat the same amount of calories. You can exercise the same amount, and guess what? Your body laughs at you. It says, ha ha, I'm going to pack it on. And I'm going to pack on a lot. Because we think in terms of evolution, when you think about evolutionary biology, we only need one man to repopulate the planet. But we need a lot of grandmas. We need a lot of grandmas who can survive not one famine, not 2, but 7. who can say, you know what, when it rains again in 7 years, that plant is going to bloom, and then you can gather those seeds and nuts. So that's why we pack it on, and that's why you can't lose it very easily. And some of us say, and it was a bunch of experts from Stanford, Harvard, Duke, so we're not talking people who don't know anything. They're saying the only way, really, for women to lose weight in menopause, and I paraphrase here, is to wire your jaw shut and chain yourself to the elliptical. It's not, I'm making a joke because we can't eat the same way we used to, and we have a slight, very slight insulin resistance. This is evidence-based, so it's not your imagination, and you're not bad. You're not bad. You're not bad if you say, gosh, I can't even have a half of a brownie without packing on 5 pounds. It is not your imagination. But it's hard to feel hot and sexy, okay, when you're wearing granny panties, right? It's a little bit hard to do that. Thank gosh for dark lighting. So what happened to my libido? Remember, when you go through menopause, it's like puberty in reverse. So think about, if you can't remember back, because maybe you're having night sweats, you can't remember back to your own pre-puberty, when you were like interested in playing with dolls and you weren't really interested in boys, as your estrogen levels drop, it's normal and natural for some women to have a decreased interest in sex. It's normal and natural for some women. Now, some women have more interest. Some women, their interest is about the same. But as our ovaries age and as our estrogen levels drop, so does our testosterone level, because our ovaries also produce testosterone. There's some other things that influence our sex drive. If we've had some bad experiences with sex, if we've had pain, if we've had a negative sexual experience, if we have some fear of maybe we're going to leak a little urine, if we have teenagers at home and we don't want them to hear us, that can interfere. If we have relationship issues, and let me say this, if you've been married for more than a few years, it's very likely that you may have some communication issues. You may have some unresolved anger. That's very normal and natural in any long-term relationship. Also, if there's any kind of pain or fear of pain, which can happen as estrogen levels drop, and as Dr. Levine will tell you, you have more estrogen receptors in your genitals than anywhere else in your body. So as your estrogen levels drop, one area of your body that's particularly sensitive to that change is your genital area. So we know that at menopause, your estrogen levels drop, the vaginal tissue changes. So having less estrogen means that the vagina isn't as flexible. The vagina has a lot of folds in it. It's like an accordion. Remember, a baby's head has to come through there, right? So it has to stretch a lot. As estrogen levels drop, it gets drier and thinner. It's less likely to lubricate on its own. And so many women all of a sudden will say, gosh, I need to use a lubricant. In fact, if you need to use a lubricant, you're in good company. 50% of all women of all ages need to use a lubricant. And we estimate it's more like 75 to 80% of women over menopause. So intercourse may become more painful. My patients tell me that unless they're using estrogen, their orgasms are less powerful. Instead of being like a tornado, it's kind of like a little breeze. Like, it's not as powerful, but okay, at least I'm having them. That's good. So as we get older, things do change. One other concern are urinary tract infections, and I think this is a good place to segue to my friend and colleague, Dr. Sari Levine. Now, Dr. Sari Levine is a board-certified urologist who has been with El Camino Urology Group since 1991. Her practice encompasses all aspects of urology. She treats men, women, and children. I've been referring patients to Dr. Levine since 1991. She has particular expertise in treating patients with voiding dysfunction, neurogenic voiding, and incontinence. Dr. Levine graduated with honors from Stanford University and the Medical School of Washington University in St. Louis. In addition to managing a busy urology practice, Dr. Levine has also served in several important leadership roles at El Camino Hospital, most notably as Chief of Surgery in 1998-1999, and Chief of the Medical Staff in 2004-2005. So I'd like to welcome Dr. Levine. Thank you.
Dr. Levine. That's okay. Thank you. So, the flu. I did a flu shot. 23% of those viruses were covered. I've got the other 76, whatever. So if I step back, I'll cough, but otherwise, excuse that. So fair disclosure, I am a urologist, and that means I don't venture into who takes systemic hormone therapy. I rely on my gynecologic colleagues. But one of my favorite gynecologic colleagues told me something that I quote often: if estrogen is so good for you before menopause, how can it be so bad for you after? So there's been obviously a societal push that says, oh, honey, it's too dangerous. You can't do that. Suck it up. So as a urologist, I see 70-year-old men who wonder why their wives don't want to have sex. Is this on and going on in and out?
I'm lowering a little bit.
Okay, because I can talk loudly without it. That would be fine. So when women at 50 are told it's too dangerous to take hormone replacement, then they're left with all those vagaries of menopause around sex. No libido, so no interest. By the time I see their male partners for their erectile dysfunction in their 60s and 70s, their partners haven't even remembered ever liking sex because it's been so long. So that's a challenge that I can't really broach because it isn't really in my purview. What I can do and try to do is make it not hurt. So if sex doesn't hurt and you don't hate it, at least then you might be willing, if not eager, right? So that's where my sort of journey led me, because I don't profess to be an expert on the 90 studies that suggest whether women should be hormone replaced or not, and the newer ones that suggest younger versus older and all of that. I rely on the gynecologists. But the vagina needs more help in the women who have never been hormone replaced, and even in those that have, because it doesn't respond the same. Hormone replacement that you take after menopause isn't the same as the hormone levels before menopause. So the vagina feels it. Now, urinary tract infections obviously are my area of expertise, whether I wish it or not. And why do women get urinary tract infections? We always ask about their sexual activity, but UTIs aren't a sexually transmitted disease. It's the mechanics of intercourse. So another one of my often quoted, I made it up, is that, of course, if there's some supreme designer of the female body, it wasn't no woman, because it's a design flaw, where you have a sinkhole in the middle of the body and all the holes that go in and out are too close together. So the bacteria that causes bladder infections are women's own bacteria. They're not getting it from him. He's the vector. So the penis going into the vagina carries the bacteria from her anal area to her urethral area. It's not supposed to be there. Then you add the friction of the loss of estrogen with dryness and the lack of lubrication, and that friction irritates the urethral opening. So it's more receptive. Come on, guys, be my guest. Here's a ladder. So that bacteria that's supposed to be down around somewhere else is brought nearby, and the area is irritated, and the bacteria gets in. So where do you start? You start by increasing lubrication. If that doesn't work, well, you have to do that too, but you have to get up afterwards, you have to urinate, and an adaptation, drink water then. Why? Because you dilute any bacteria left behind, and you have to pee sooner, so you get rid of any that are stragglers. That usually works. If that doesn't work, you need me, because then we start the idea of getting urine cultures to make sure we know what bacteria is growing and how to best treat those infections. But we can also use small doses of antibiotics for prevention, because preventing the infection is key, because then the bladder has a chance to heal and becomes more defensive against those recurring infections again. Okay? So that's the UTI talk in a second. Okay, so from my perspective as a urologist, I think estrogen cream is like candy. I want to prescribe it to every patient that's menopausal and having sex, and even those who aren't, because really, and I don't do the ring as much, because my experience is it's not inside the vagina that needs as much help, it's the entry point where the tissue really does become inelastic and rigid, and it feels like you're going to tear in two when you have sex. So if you just take a tiny little bit of estrogen cream and put it around the urethral opening and the inner lips and the bottom of that vagina, see, your vagina, I bring it with me wherever I go. That's my other shtick, right? I used to have pictures, this works, doesn't it? Isn't that what it looks like? Clitoris is up here, urethra's right below, this is where, it works, and it's with me wherever I go. So massaging and working on the bottom end is what allows the penis to enter without pain. So you don't need a lot of cream inside. It's a waste, it's very expensive, and it isn't really necessary. So for the women who worry about the dose of estrogen, a little toothpaste of it twice a week isn't going to hurt anybody, but it helps a lot. So again, the systemic, so looking at the pills or the patches or the gels or the sprays, I defer. I don't prescribe those because I'm not the gynecologist who's supposed to work with you on your specific risk and your needs for systemic therapy. But mechanically, we can make the vagina a happier place. So there's also the FDA-approved oral pill called Aspina. And I've had very little patient experience with it because it's very expensive. And it's a pill every day as opposed to a little bit of cream on the outside twice a week. But the few patients that have been willing have really thought that it replaced the need to add anything to the vaginal tissue, so it's an option. But that's an expensive one. It's about $150 a month. I've got it down now. So Medicare pays for Premarin cream, which is one of the estrogen cream available, and it still costs about $95. But that tube, using it my way, without the applicator, I tell patients, throw the box away, because if you read it, you'd think you're going to die, and throw the applicator away, because if you use it, you're using too much, you're going to scratch yourself, and who can keep that clean? It's got to contribute to infection. So throw the applicator, throw the box away, and put that little bit, that tube will last you 6 to 9 months. You're worth it. It's like L'Oreal, right? $100, you're worth it. So that's it. And then Estrace for non-Medicare patients, they came to my office, there are discount coupon samples, so it can be affordable with the bit, with preparation, perhaps. The lubricants, I think we have samples, there are several different. I don't usually venture into testosterone for women. It's not really approved yet in this country, and the biggest problem is dosing. So that isn't something that I've ventured into, but I haven't really found that I'm missing that because I have good gynecologic colleagues who are doing all the hard work. And then I don't do the devices, but I'm not even certain that the blood flow is necessary if we can make everything else feel better. And so that's really an easier place to start. This would be a more advanced work on we've gotten everything comfortable and now we need even more help. So sexual desire is sort of an interesting concept because as many things in medicine really are, multifactorial. Lots of different things contribute. So we talked about some. You don't feel good about how you look, you won't feel good about being sexual. If your relationship isn't on the kind of intimate ground you need, and I think that, you talk about men are from Mars and women are, I can't remember the book name, and you kind of remember. I really do believe that for men, being sexual is often that physical release. And then they go to sleep. It just works. For women, it's an expression of the intimacy. They're entered. Their boundaries are crossed. It's intimacy. So yes, there's a physical release. And yes, it's an active process, perhaps. But often, the needs and the interests and the symbolism behind the activity are so different that if those differences aren't addressed, then you're in different places. And it becomes a more challenging activity. Because you've been married a long time and, it's not like, there were movies about it's a sure thing, it's kind of a sure thing, right? You're legally responsive to each other, supposedly. But we have to manage the relationship and not underestimate its impact. It isn't rocket science. If you're not nice to each other during the day, it's not likely that being sexual together will be particularly satisfying for at least one of you. You never know which one, right? Okay. So, components of desire, again, you can already see just by a quick look at the slide that there are many things that contribute. And I really try hard not to underestimate the non-physical. Because if you have depression or anxiety or stress, you feel overweight or unappealing, powerful impact on suppressing desire. And again, we'll keep hitting the same things over and over again, but we aren't able to fix your relationship. You have to do that work. All we can do is give you some ammunition to go home and say, I have this crazy doctor. All she wanted to do is talk about sex, and I think we really need to talk about it. That's what I try to do. And don't underestimate the physical either. If you look at alcohol, drugs, in our practices, we're kind of in a very protected place and demographics, and that's great, but medications suppress, lots of different things, lots of orthopedic issues, everything as you get older has an impact on your willingness to venture into being sexually active. So sexual dysfunction to me is anything that isn't what you wish it to be with the partner that you're with. That's dysfunctional. He wants it more and you want it less, that's dysfunction. You want it more and he can't, that's dysfunction. So first you have to identify your expectations, then you have to see which can be addressed through medical advances and which need to be addressed in the background. Trying to functionally make sex better, you first have to figure out part of what the problem is. And from my practice, my perspective, I will say over and over again that coming to the office to talk about, it's not that common for me to have someone come just to talk about sex. They have easy entry, though, because they've had a urinary tract infection or some incontinence or there are other issues, and we usually try and then incorporate that. So the doctor has to be brave enough to talk about it, and the patient has to be brave enough to think about it, and to be able to start to sort through what the problems are. So I am not as able to help with having a patient reach orgasm. That's challenging. First, you have to just make it so it doesn't hurt. And again, that's the starting point that I think is completely underestimated and underaddressed, and no one likes to talk about it. I don't think that when I went through residency in Philadelphia and into practice that I thought I was going to talk about sex so much. But very early on in my practice, I realized that no one talks about it. So if I don't, who's going to? So it became just, I force myself to speak about it as naturally as it ought to be, so that we can get past that. Barb just gave me a cue, and you're absolutely right, because one thing that we are talking a lot about, and we have men in the room, so I sort of got distracted. That's absolutely correct, because it isn't always male partners. Sex is being physical and intimate with anyone you choose. And it isn't always penetrating intercourse, but even women who don't wish to have penetrating intercourse will not feel as good if that vagina is unattended to. So it still needs to be lubricated and moistened, and the estrogen still makes that vaginal tissue more vibrant and responsive. So whether or not it's elastic enough to have a baby come through it, obviously that was behind us when we're talking about menopause, there's still value to making that tissue more comfortable. So male sex dysfunction really isn't the topic of our talk today. One of the other things that I sort of rant about, I think, in my practice, is that you can't watch a sporting event or watch TV and not hear about low T. God forbid a man's testosterone level should get low, because of course that's just a tragedy and we need to do something about it. And as a urologist, I was fascinated fairly recently because one flawed study came out, and of course the newspapers picked it up and put it in the newspaper, that suggested a relationship between testosterone replacement and heart disease. Now, to me, that was a no-duh moment, because of course, why have women been told they're not supposed to use estrogen? Because there's a relationship with heart disease. So I had a much different response to that study, but what fascinated me, so I was like, okay, so you have to pay attention, right? Just as I encourage women to tell their doctors, okay, so let's pay attention to my heart. Let's make sure I exercise, let's do regular exams, but that shouldn't mean I can't have estrogen. It just means we have to pay attention, right? Well, the world, across the world, the urologic community banded together and demanded that the study be pulled from the literature because it was flawed. Fascinating. Not just, there might be a relationship. We want to absolutely throw out this study because it might, and I agree, the study was flawed. But boy, was that a unified response to the idea that we might suggest not to replace testosterone. Do you see the world standing behind the idea that perhaps women would be better off with estrogen? I just am not certain why that might be, but it really struck me that our whole medical community just didn't quite get that. So, again, I replace testosterone often when necessary, but it doesn't fix all the problems either. And I counsel men in the same way, that relationships have a whole lot to do with the decision to replace and the benefits. Yes, we sure are complex, aren't we? So I'm not gonna read these to you. We kind of are getting the idea already that if you add on all sorts of negative things, sex loses. And the only way to make a physical, intimate relationship positive and enduring is to make sure it doesn't hurt, make sure it's safe, and make sure that you address the things that make you want to be intimate with the person that you're choosing to share that secret part of your life. Because to me, that's the one thing that's different than your relationships with anyone, with your best friends, with your kids, with your colleagues. You have someone now, granted, I'm not venturing into monogamous versus non, and that's your business. My business, my personal sense, is it's complicated enough to be sexual with one person. I can't imagine being sexual with more than one. So I'll focus on the one. And that's just us. It's sort of like why I loved nursing my babies, because I had the world's greatest nanny who still comes to take care of my 16 and 14-year-old. But no one else got to nurse those babies but me. And it's nice to have that private, separate, different relationship. So, my kids know this. This is about incontinence. Carol Channing comes on the TV and says, "Oh, I've got the solution to your incontinence. These great Depends," and I scream at the TV, "Call your doctor!" And my kids change the channel because they know that I go crazy about stuff like that. So if you don't talk to your doctors, you don't get help. Yes, there are products. Yes, there are things you can research on the internet, which is a good and bad thing. But sometimes your doctors have some tricks, and that's the idea. So if you have issues, you need to start with the doctors, and if you're not getting help, go to Nurse Barb, because she's awesome. Counseling, I did a panel once with a sex counselor named Mary Buxton in our community. If you do sex counseling in Santa Clara County, you get Mary Buxton. And I haven't had tons of feedback, but I loved her and how she spoke. And so there really is help if it's the mechanics that are the problem, how to. But if it's pain, boy, have we been making progress between vaginal estrogen cream, talking about it, and getting into our pelvic health physical therapy program. We make a big difference. And that's something that I have been incredibly grateful to El Camino Hospital for, because physical therapy sounds like, oh yeah, physical therapy, right? We all know what it is. Pelvic physical therapy is completely different. And these lovely, we have one at Los Gatos and one here, and these wonderful women stick their fingers in your vagina and they make it feel better. And I know that sounds crazy, but it helps urgency and urge incontinence, it helps pain, and it helps teach women how to strengthen when they're supposed to be strong down there, and how to relax when it's supposed to be relaxed. And boy, you'd think it's intuitive, and somewhere that intuition gets derailed and it's backwards. And they're tightening when they're supposed to relax, and everything's wrong. And then it causes pain and urgency and all those other things that are really unsettling, and they get people back on track. So I don't know what I do. I probably refer at least a person a day for physical therapy. And so there are things, and I try and prepare them. I mean, I definitely say it's unlike anything you've experienced, and it's intimate, and get over it. Tough. And that usually works. Plus a little vaginal estrogen before they go, so it doesn't hurt so much when they have their treatments, and it usually makes a difference. Got to talk to your partner. If you can bring them to the doctor with you, that's better. I like it when I have couples, because I can, you can kind of tell I'm irrepressible. So I'll make a few jokes and I'll be very direct. And so I can explain what it means and how. to actually have sex. I'm not a sex therapist, and I don't go beyond that, but I can bring my vagina with you. Or your vagina with me, I guess is what I meant to say. And as I said, and as I really want you to understand, that penetrating intercourse isn't the goal. And as women age, obviously men do too. So if they do have a male partner who is older and who has erectile dysfunction, it does not mean that you can't be intimate and physical with each other. Yes, we have all sorts of things we can do to recreate erectile function. But sometimes when the vagina hurts and when it isn't as elastic, maybe that's not the best choice for the two of you. But exploring and being comfortable and being intimate and being sexual still may be. So, all those nagging, annoying things. Eat healthy, exercise, don't smoke, sleep. But the most, I think, important thing is the confidence. If you feel like you can be sexual, you will be. More likely, anyway. Oop, I missed one. So, we have some products. Lubrication is incredibly important. You need it less if you use vaginal estrogen, but you likely still need it, even if you are. I'm a kind of a fan of the self-dilators. That especially in women who have developed a lot of spasm in the pelvic floor so that it's painful even if they're lubricated. When they use a dilator, they can figure out how to relax those muscles. It's not always particularly sexual to do, so having your partner do that may not be what you want because it can be uncomfortable. But it's like doing your own massage. You have to get in there and work those muscles, and sometimes that really does help. So I've become incredibly brazen. Because every doctor is now going to electronic records, I'll be sitting with my laptop, and I'll go to the solutions catalog, and I find vibrators. But I call them dilators because I don't like the ones that look like a penis. That's kind of off-putting. I like the ones that are smooth and that you could imagine you use to massage and dilate that vagina to make it less uncomfortable. Can't be shy. The first thing that we figure out quickly when people come is whether or not the reason that they're having a lot of discomfort is because they're too shy to try to address any of the real issues. So I'm not even delving into the concept of the cultural differences and anything else because it's so beyond the scope of tonight's talk. But believe me, we recognize the overarching impact of being taught not, or not being taught, to even consider that sex is supposed to feel good. If you're not taught that when you're young, how are you supposed to pursue it when you're grown up? Okay, so these are easier, the big O. It might work, it might not. And again, orgasm's a great goal, but being physically connected and intimate is probably really the goal. Everything else has to be in place. And so if all you're focusing on is the end point, you may miss the journey to get there. So lubrication, foreplay, all of these things, again, not rocket science. But if you rush to get to the end, you miss the fun all along the way. And so it's taking time to feel again what feels good, what makes you feel good, what makes your partner feel good, what makes the process more connected and intimate. Music, candles, all that good stuff. Okay, so having a TV in the bedroom and watching SportsCenter, not so much. So I always look at that and kind of wonder, because doesn't it look, well, anyway, I'm wondering whose feet are whom's, but that's okay. Sorry. So finding out what your partner needs is just the kind and polite thing, don't you think? But in our world, women do a lot more of that than men sometimes. That was kind of wishy-washy, but you know what I mean. And so make sure that when you're venturing into what your partner wants, that you figure out what you want too. And make sure that you get those needs met while you're figuring out how to please the partner. We've talked about simple things and complicated things, and we've alluded to things. It's not easy to give these kinds of conversations in front of a lot of people. My goal would be that you begin your journey here, because now you realize that there are certainly places to go and things to ask to get questions answered. This isn't going to be the end of how to fix you. It's the beginning to figure out if there are things we can do to help you. So health perks, I know that I saw at the bottom of the papers on your chair. Health perks is a very inoffensive membership. Don't be afraid of it. All it means is that you get a few early notices on talks, and you get maybe some discounts, and it's just really a great way for us to be able to communicate what we have planned and get you in kind of at the ground level. So I strongly suggest, if you're not already members, that you become a member. The Menopause educational page, I kind of forget about all these things. These are the websites, and I presume, Bonnie, that we have these written down somewhere. They don't have to quickly scribble, right? And the Pelvic Health Program has really, I can't express to you, in the 23 years, I can't believe that I've been here, how different it feels to have it as an option for my patients. It has changed my practice by having this resource. Because before, all we really had was medication for urgency, and we weren't as aware of the complexities of that pelvic floor and how it affected so many other things.